Hi and welcome. I'm Vicki Shaw, physician assistant, part of the editorial board for Clinical Liver Disease Journal, our multimedia platform. And so today I'm here with Dr. Kanika Garg, and she comes from Rush University, and we're going to be discussing common GI medications that could be implicated in drug-induced liver injury. Thank you so much for joining us today. I'm really excited to talk about this really important topic. So we know that DILI, or drug-induced liver injury, is the most common reason for acute liver failure and the leading cause of removing drugs from the market if it's already FDA approved. So specifically, let's go over some GI medications that you wrote about in your article. So let's talk about PPIs first.
Yeah. PPIs are a really important one because this is something that's prescribed so commonly, not just by gastroenterologists, but also primary care physicians. PPIs can lead to a specific pattern of hepatocellular injury and can even cause a specific type of injury that's seen on liver biopsy, though liver biopsy is not necessary to diagnose DILI from PPIs. The onset of injury is usually within 1 to 4 weeks, and then the injury can be recovered very rapidly after cessation of the drug. One of the really important things to know about PPIs, though, especially in patients with liver disease, is that it can increase your risk of infections, particularly spontaneous bacterial peritonitis and C. diff. And all of these in combination can also increase your risk of hepatic encephalopathy. So it's very important to be aware of these risks and make sure that patients are appropriately on PPIs and stopped when they no longer need the therapy.
That's good to know. So let's go into inflammatory bowel disease. Let's first talk about azathioprine and its association on liver injury.
Yeah, azathioprine is a commonly used medication for IBD. There is several different patterns of injury that is seen with azathioprine. Most of them have an onset within the first 3 months of treatment, and luckily the injury is usually resolved after a few weeks of cessation. There is specific patterns of injury that are seen in patients with IBD with nodular hyperplasia and sinusoidal dilation, but again, it usually the injury resolves after a few weeks of cessation. But because there's this threat of injury, it is important to monitor liver function tests and platelets in patients who are on this medication. And then usually it's not recommended that you try a trial of it if a patient has any sort of injury, then it's kind of off the table for that patient.
Okay, great. So let's talk about a medication we use in IBD that's usually a first line, like sulfonamides.
Yeah. So sulfonamides can also lead to a mild to moderate mixed pattern hepatocellular injury. Again, it can happen within the first few weeks of starting the medication. And interestingly, there's also another hypersensitivity reaction that's really common with these medications that includes a prodrome like fever, chills, and just B-type symptoms where the patient's not feeling well. And interestingly, that's seen less common with the unconjugated 5-ASAs like mesalamine. And then there also have been a few cases reported of acute liver failure with sulfonamides, so just important to remember.
Okay, great. So next I want to talk about methotrexate. We use it in IBD, but we also use it across the board for different types of autoimmune diseases, including rheumatoid arthritis. So let's talk a little bit about methotrexate.
Yeah. So methotrexate is a medication that can be given orally and also given IV. And in both cases, we can see an increase in serum aminotransferases. With IV medications, it can be a lot higher, and then even with mild doses, you can see mild elevations in aminotransferases. There's also a risk with chronic therapy of steatosis, fibrosis, and cirrhosis with methotrexate, which is why with someone who's on chronic methotrexate therapy, it's really important to monitor for fibrosis, because there's actually a 20% incidence of fibrosis in patients who are on methotrexate for more than 2 years, which often is the case with patients who are on methotrexate. And luckily, usually when the medication is stopped, the levels return back to normal of the aminotransferases. So it's important to monitor levels and monitor for fibrosis.
Great. And I think the last category is biologics. So we know that biologics also can cause hepatocellular injury, but I think one thing we always have to watch for when starting biologics is reactivation of hepatitis B, and so monitoring that and treating prior to starting a biologic is going to be really important in our IBD patients. So this is wonderful. Thank you so much for joining us today. If you want to read more on Dr. Garg's article, please visit Clinical Liver Disease Journal with AASLD, and thank you.